Here we go. Welcome to Perfecting PT, everybody. Happy to have you again. Today, I am joined by Dr. Jen Stone. She is a pelvic health therapist as well as a program director for Evidence in Motion, and she will kind of be our guide through the mysteries of the pelvis today. Would you like to say hi to anyone, Jen?
Sure. Anyone and everyone. I know you got my name from Nick Rainey, so always a pleasure to interact with anyone who's interacted with him. And yeah, I'm just really excited to get to chat with everyone who's listening about the pelvis and the pelvic floor.
Oh, me too. So I'm pumped because I feel that I don't know much about the pelvis, and we were for anyone listening, just know if this is your first podcast joining us, these are candid conversations. They are not edited. We're going to chat, and our conversation is generally going to flow through. Oh, I dropped my water. Our conversation is generally going to flow through the essentials, need to know things from the perspective of an expert, and I will do my best to ask questions that will help you that are listening. I was told by a friend of mine I need to provide objectives. So for anyone listening, yeah, he listened to it and he's like, Nate, I love the podcast, but you should probably tell people ahead of time what they're going to find out about the topic. So some objectives, because Jen has already told me beforehand, we are both talkers. So we'll give you some objectives before we start going off on that. We would really like to go over a couple things. First off, what is pelvic health? What does it relate to? Both men and women. Oftentimes people aren't as aware about pelvic health for men. And realistically, we want to talk about what are the main presentations of pelvic health. How do you know if you should seek out pelvic health or another healthcare provider's expertise to address what you have going on? And then we're going to walk through the evaluation process of pelvic health issues, breaking it down into the subjective portion, kind of what's important to ask a patient, what's important to tell a provider if it's you, how to assess it. Obviously, there are certain types of credentials that need to be had if you want to do a full pelvic health assessment, which we'll get into. And then how do we begin to treat these things? So essentially, we're going to overview the evaluation process, what pelvic health is, what it isn't, how to know you're in the right place, and identify the buckets of interventions that will be available to you if you are a provider or seeking someone's help with this. So, Jen, I'll kind of start us off. We were talking before about the things we hate to hear about pelvic health. I'll kind of start off with a couple, and you can just ramble for as long as you'd like about the other things to overview. I brought up that I hate when my friends either just had a kid or my mom who's in her 60s or someone else I know is in their 50s, 40s or had a few kids. And they're like, get used to just peeing yourself every time you laugh, or I can't jump on the trampoline because I'll pee myself, or well, of course sex hurts after, I've had a kid. Like it's only been 3 months. Or, oh, I can't run because I pee myself, or it hurts. And they get any number of presentations. And you and I were both talking that it's so frustrating to hear people normalizing that when in fact those things are not normal and can be addressed. So I'd love to just kind of start off with your thoughts on like, what is pelvic health and what are the common misconceptions that people like, oh, that's normal, when in fact it isn't?
For sure. So pelvic health is I consider it a somewhat broad term that can apply to, of course, multiple different areas. But when we're applying it to rehab, so physical and occupational therapists both treat patients with pelvic floor dysfunction. When
Okay.
I say pelvic health, what I mean is I am working with someone who, generally speaking, probably has a suboptimal motor pattern or something that is not working optimally within the pelvic floor, which is a group of muscles that everyone has at the bottom of their pelvis, regardless of if you have male anatomy, female anatomy, everyone has a pelvic floor. And possibly I'm also working in the abdomen. Now, I don't think that the abdomen needs to necessarily be only people who are pelvic floor trained, but it just so happens that there's a lot of overlap between what's going on in the abdomen and the abdominal organs, especially the bladder, the GI system, and the reproductive system. and the pelvic floor, and then also the abdomen and the pelvic floor. So a lot of times the pelvic floor therapists are just also the ones who've had the most training in abdominal mobility and retraining and anatomy and that sort of thing. So I could be working with people who have symptoms of things that sound like maybe they should be in to see GI, or that sound like maybe they should be in to see someone in reproductive medicine. There's a dirty little secret though. A lot of those issues are actually musculoskeletal problems, believe it or not.
Okay.
For just to
Yeah.
give you an example,
Yeah. We'd love
did
some.
you know that there is stronger evidence for pelvic floor physical therapy than Viagra when it comes to treating erectile dysfunction?
No.
Because erectile dysfunction is a blood flow issue 99% of the time. There is stronger
Fascinating.
evidence for PT than there is for Viagra, but nobody knows that. Partially
Okay.
because there aren't enough physical therapists that are and occupational therapists, sorry, I always forget to be inclusive there, but there aren't enough providers who are
Sure.
truly trained with a lot of these issues. And so what ends up happening is you may have, a 6 to 12 week wait list or more to get into a provider in your area. And so, we just live in a society and a culture where it's like, well, the understandably the physician's going to be like, or you can take this medication and it will address. So, yeah, we could
Right.
be treating anything from something like that to constipation to incontinence, and the list goes on. However, the most common things that I actually treat are probably similar to the things that if you're in an outpatient orthopedic setting, and any of your listeners who are in that setting also treat low
Hmm.
back pain, pelvic girdle pain. Some people call it SI joint pain, but pelvic girdle pain and hip
Okay.
pain,
Oh,
because
okay.
all of those can have a very strong pelvic floor component. One of my favorite statistics about this, and this is not new, but nobody knows it. So in 2018, Van Dyken and colleagues did a study where they looked at patients who are assigned female at birth who have chronic low back pain. So that is important. It's chronic low back pain.
Okay.
95.3% of them had at least one objective measure of pelvic floor dysfunction. 95.3%. What that means is that if you treat patients who live in female bodies, you're already treating people who have pelvic floor dysfunction. You
Hmm.
just don't know it because you're not asking them. And they
Hmm.
don't know to
Okay.
bring it up because they have no reason to think that their low back pain and their incontinence are linked.
Hmm. Okay. So
So,
can I interrupt you for a second?
yeah, please.
So I love the direction we're going. For anyone wondering, I would really like to hammer down the list of so you brought up like constipation, we
Hmm.
brought up incontinence, erectile dysfunction, low back
Yep.
pain, hip pain, pelvic girdle or SI pain. Would there also be, so what are some of these other presentations
Hmm.
are going to be involve the pelvic floor? Like it, let's say like, is diarrhea also an issue?
Yeah, it can be for sure. And
Okay.
I am I wanna be super clear that I am by no means suggesting that all GI issues are pelvic floor issues or are musculoskeletal.
Absolutely.
We do need to assume that we are ruling out some of the more concerning, dangerous causes of these issues, but there is a very large percentage of people, and they often end up walking through my clinic doors, who have been to all the specialists, sometimes for years or decades,
Hmm.
and they've tried all the medications, they've gotten no answers, and it ends up being something relatively simple to address. So, yes, it can certainly be diarrhea. It can be the opposite of incontinence, where people have difficulty voiding or being able to initiate a stream of urine from their bladder. And then there's a whole slew of issues that I would not say pelvic floor therapy necessarily treats in the sense of cures, but it
Okay.
can help significantly with the management of. So that would include things like endometriosis,
Hmm.
irritable bowel syndrome, Crohn's disease, some
Hmm.
of those other items, where no, am I going to change with my hands and my magical exercises? By the way, I don't have magical hands or exercises, but if I did, would I be able to change the fact that you have endometriosis? No. But can I help change the amount of discomfort that your body feels and the amount of side effects that you're having from your endometriosis? Almost certainly, yes. So there's also sort of that category of items. And then there can just be what a lot of people will call chronic pelvic pain, which is a little bit It's a little bit tricky because it's not super specific. It
Hmm.
is similar to chronic low back pain, where it's like, unfortunately, we don't have some nice, neat special tests where we can, boil it down. But
Sure.
generally speaking, that diagnosis refers to pain anywhere between the umbilicus or the belly button and mid thigh that has not been explained by some other issue. So again, we're assuming we've
Diagnosis.
ruled out cancer, et cetera. And there are actually quite a lot of people who experience that. And then we said erectile dysfunction, but I would broaden that to sexual dysfunction. So pain with penetration, premature ejaculation, erectile dysfunction, difficulty or inability to orgasm, those sorts of things can all be potentially addressed or at least assisted with pelvic health therapy.
Oh, awesome. So I will try to recap that in case anyone's like, wow, she said a lot of things.
She did.
So
Sorry.
no, that's okay. That's okay. And that's the purpose of podcasts like this. So if we talk the broad list, it looks like you can deal with things like constipation, diarrhea. You can help, not cure, but help with things like Crohn's disease, IBS, endometriosis. Would it also help with things like colitis?
Yep.
Okay, great. We are essentially looking at any pain between the belly button and the mid thigh that hasn't been ruled out as another orthopedic issue or a red flag, and other type of continence or sexual dysfunction, either having a hard time peeing, um, having accidents, fecal incontinence, inability to poop as well, and sexual dysfunction, including erectile dysfunction, having a hard time orgasming, painful penetration, and did I miss any?
Premature ejaculation.
And premature ejaculation. So that's, I mean, obviously, I'm sure there are an almost infinite number of things, but it sounds like if you're dealing with something that seems odd to you between the belly button and the mid thigh, it could be that the pelvic floor is contributing at least some, if not to a larger degree.
Yep.
Would you say that's an
That's
okay
fair.
summary?
Yep.
Okay. So when someone was there anything you wanted to add before I kind of move us along?
No, I think that's a great summary.
Okay. So when someone comes into the clinic, um, well, and I guess for anyone listening, if you didn't hear, pelvic health is a severely underserved population. Um, if this is something you're interested in, please look into it. I know friends that have been dealing with things like this. I told them to contact a pelvic health therapist, and like Jen said, you're looking at 6 months to a year.
Mhm.
So there's a huge market, and not just for women, but also for men.
Mhm.
So it's a huge market.
I got curious yesterday, actually, not because of this podcast, but just randomly. I was like, how many pelvic floor therapists are there? I can't find anything that allows me to estimate how many occupational therapists there are, but
Sure.
APTA estimates think that there are somewhere in the neighborhood of a little bit um, under 10,000 therapists, which sounds like a lot until you realize that there's something like 40,000 to 60,000 patients at any given time who
Yeah.
might need pelvic health.
Right.
And what's trickier too, I think, is that it's fairly common, like, it's like, "Oh, but 10,000 should be enough." The problem is they're clumped, right? So in, let's say, Chicago, there's probably a pelvic floor therapist, not on every block, but likely you have one within easy driving distance no matter where you are in Chicago.
Sure.
I live in not a tiny town, but a mid-sized college town in Missouri, and the reason that I got into pelvic floor PT was my oldest introduced me to the world of pelvic floor dysfunction very much against my will and very abruptly. And after I got the medical treatment and unfortunately a surgery that was necessary to help me with the acute phase of that, the next step was, can you drive 2 hours each way once a week to go do rehab? And my answer was, not really. I have a baby and I work full time, and no, that doesn't work. But that was at that time the closest. And at that time, there were only 3 therapists in the entire state of Missouri, which is not a tiny state.
Yeah.
Now there are more because I might have a bad habit of reeling people over to the dark side. But at that time, which that was only 12 years ago, there were only 3.
Ah, wild. Well, and I remember I was living in Utah at the time, And I think there were two or three in northern Utah. And for
Probably.
anyone who has ever lived in Utah, you know those guys are popping out babies.
Yeah.
Like the young people in Utah are having kids. And so, that's a little aside, but for anyone interested, please look into getting into pelvic health. We'll talk a little bit more how to become a pelvic health therapist more towards the end once we've kind of walked through some other stuff. So so Jen, when a patient comes into you and they are like, "Well, I was referred here for pelvic health," what are the big things that you and it may be a long list, but what are the kind of these list of questions you're asking? Let's say first off, to make sure they don't need to be somewhere else.
Hmm.
Like, how are you clearing red flags before you even get into deciding how you're going to treat them?
Yeah, that's a great question. And it's actually something that I had to reformulate in my mind fairly significantly when I got into pelvic health. So, a small aside, but my background, I jokingly say that I was dragged into being a pelvic health therapist against my will. It was the one area of PT and physical therapy school that I was like, don't want to know any more about that. Thank you very much. That was largely due to the way that we were exposed to it, which was suboptimal, to put it mildly. But I was extremely opposed. Didn't want anything to do with that. Didn't know what it was. Definitely not interested. But I loved orthopedics in PT school and continued loving orthopedics. So I did an orthopedic residency right out of school. Had great mentoring and all of that. And I always really enjoyed treating patients with spine issues and hip issues
Mm-hmm.
and pelvis sacrum issues. Although I'm not going to lie, I kind of hated the pelvis in PT school because it didn't make sense to me. And it was like up slips and down slips and nutations and counter nutations and what in the world. And it didn't click in my brain and make any
Sure.
kind of sense with regards to driving treatment. So actually the pelvis was probably of those areas the one I was least comfortable with.
Mm-hmm.
And then, like I said, my oldest delivered in such a way that I found myself in need of pelvic floor therapy. And even when I went for my first training, I honestly did not have any intention of offering this service clinically, to be really honest with you. I was going to learn how to take care of myself, and that was kind
Sure.
of it. And then I came out of my first class, and of course people were like, oh, how'd it go, how was it, because they knew I was pretty nervous and didn't really know what I was getting myself into going in. And I said, I am excited and I'm furious. And they were like, what do you mean? I was like, I'm really excited because this is musculoskeletal physical therapy. This
Mm-hmm.
is orthopedics. It's just a different body part. And I'm furious because at that point, again, I had gone through a well regarded orthopedic residency
Mm-hmm.
and I had sought out just on my own. Again, I loved these areas of the body, lots of courses
Mm-hmm.
regarding this area of the body, never even heard the names of these muscles, let alone what on earth do they do. And then I go to this course and I find out,
Sure.
oh, this is an integral part. Like, this isn't just the people it is the people who are having trouble with incontinence when they're jumping on trampolines or who are having pain after having a baby. But it's also, like I mentioned earlier, all of these other people that I have been taking care of. And so I dove in wholeheartedly, but here's the thing, a lot of the things that I was taught in my entry level education, and then also as I sought to become an orthopedic specialist, and I am a board certified orthopedic clinical specialist, by the way, and I was at that point in time as well. But a lot of the things I had learned along the way with regards to red flags and system issues end up getting a little bit more gray when you start talking about
Mm.
being a little bit more specialized in pelvic floor. For
Okay.
example,
Yeah.
I
Please.
learned bowel and bladder changes are very concerning and probably warrant an if not an immediate referral, at least like we got to raise some eyebrows and see what's going on here.
Right. I was
And
told the same.
absolutely. And now all of a sudden, most of the people walking in to see me have bowel or bladder issues.
Oh,
So it's not that
interesting.
simple anymore, right?
Ah,
And
yeah.
sometimes they've changed. And so here's the thing. I have learned, and some of this is my experience, some of this is wonderful mentors I've had along the way, and some of it is school of hard knocks, aka my patients have taught me a lot, and I'm really grateful. Your spidey senses are pretty reliable, actually.
Okay.
So if something feels musculoskeletal, if I can reproduce it, or make it better by doing something musculoskeletal, it's probably musculoskeletal.
Okay.
If it's movement related, if it is something that sounds like it could be muscular in nature. And by the way, don't forget that the reproductive system, the bladder, and the GI system are all composed of muscle.
Hmm.
It's smooth muscle for the most part, not necessarily skeletal muscle, but it's still muscle and it still responds to muscly things, if you will.
Yeah.
So there's that piece. But if you have a patient who, like, there's really no rhyme or reason, there's no response, and there still are some things that are always going to be concerning. So unexplained weight loss or gain is always going to raise some, clanging bells in the background or something like that.
Okay.
But when it comes to things like bowel and bladder changes, what I'm looking at is, okay, is this a change? If it
Hmm.
is a change, was it slow and steady over time? Or is this something, or did it happen after an event? So, like, if someone comes in and they say, "Oh, yes, I've been leaking ever since I had my baby 6 months ago," my suspicion of red flags related to that leakage pretty much goes out the window because we're
Okay.
fairly certain that we know what caused this, right? Now, it
Sure.
could come back if I do an exam and I find that there's nothing going on with her pelvic floor. That hasn't happened yet, but if it did, it would come back.
Yeah.
But that there's that piece to it. So again, it's the same skills that you already know, that you already apply with your other patient. You're just applying it to a different part of the body. Now, the other piece, though, is sometimes things that appear to be pelvic floor related are actually red flags. So I
Okay.
mentioned the evidence for treating erectile dysfunction earlier. If
Sure.
you have a patient who comes in with erectile dysfunction, you better do a very good cardiac screening because little known fact, and I'm not even real sure that this always happens at the physician level either. I obviously don't have a ton of personal experience, but from what my patients say, I'm not necessarily sure it does. Often, erectile dysfunction is one of the very early warning signs of heart disease. And I mean
Hmm.
early enough that if we catch it right now, we might not ever continue down that path and have a heart attack.
Oh,
So
interesting.
you
Okay.
better do a very thorough cardiovascular screen. And if they haven't been for a physical recently, it's probably a good idea.
Sure. So I'll interrupt you for a second, Jen. So it would seem I'll kind of give you my recap. So for anyone listening, the things you should always be aware of are sudden weight gain or weight loss. You may have been told in orthopedics that if you ask someone about their bowel or bladder function, like, oh, yeah, I pee myself. Oh, yeah, I have fecal incontinence. Oh, yeah, I have XYZ, that this person may warrant an immediate either referral to an urgent care or an ER, or at least a call to their doctor. However, when you are dealing with people who have pelvic floor issues, it appears that it's gray until you get further through your assessment, and you need to pay a little bit of attention to your intuition.
Mhm.
Um, I have noticed what Jen has said as well, where sometimes someone comes in with this is not pelvic health related. I do orthopedics right now, but someone comes in with a shoulder, and we're cruising, we're doing the things that I'm pretty confident are the problem, and then 2 or 3 weeks later, they're like, no change, nothing, hasn't, and I'm like, and then I'm like, okay, well, let's try one more week, and then we send them back to the doc, and they're like, oh yeah, they have a labral tear.
Yep.
It's like, okay. So for anyone listening, and then I'd like to, and then I'll ask you a question, Jen. So it's
Sure.
fecal. So incontinence, bowel, bladder, sexual changes are not inherent red flags in pelvic health patients. And I guess to that
Or
point,
orthopedic patients,
or orthopedic
honestly.
patients,
Yeah.
apparently.
Same
So
rules apply.
so we will get into how to assess that in just a minute. But it sounds like the only real big thing to be aware of right now, if they say, is sudden weight loss or gain. Is there any
Or
other,
systemic things, so night
such as
sweats
what?
that might indicate an infection unless they're postpartum, at which point we expect them to have night sweats. So
Okay.
that's the thing, when I started treating pelvic health, I had to become much more familiar with how these systems function, as well as pretty darn familiar with the endocrine system, which that was a weak point of mine before, to be really honest with you, because
Oh
there's
yeah.
a heavy influence of hormones. And I'm not just talking we always think, oh, testosterone, estrogen, of course. Absolutely, those ones. But I'm also talking about things like thyroid hormones and just normal fluctuations of hormones that we have throughout our life that can cause fluctuations in function in various parts of our body. So,
Okay.
really, you're looking for things that seem non musculoskeletal or that seem systemic in nature, unless we've got a good explanation otherwise. So, if we're postpartum or in menopause, night sweats may not be that concerning.
Okay.
Are we running fevers though? That's always something that, I'm not necessarily going to send you to the ER because you have a fever, but I also don't necessarily think I'm going to be able to help you with your fever, if that makes sense.
Okay. So things like fevers, night sweats, change in weight, bowel bladder functions. What other things are you wanting to clear before you move on to assess and see what you can provoke?
Yep. Neurologic system, often.
Okay.
So, bowel and bladder changes can be neurologic issues. And when I learned it in school and my orthopedic training, I basically only learned cauda equina, really, as like
Yep.
that's
Same.
probably what's going on. Is there saddle's paresthesia? Oh no, great, we're good. Well, sorry to break all of the conceptions out there, but there's a lot more than just cauda equina that can cause problems in that area.
Okay.
And so if we have incontinence, I'm going to do a neuro screen on you, even if I think that I know why you have incontinence, because just like how I just said, cardiac issues, an
Hmm.
early warning sign could be erectile dysfunction. One of the first signs of many progressive neurologic diseases like Parkinson's, MS, etc., is actually urinary incontinence. And I have caught MS multiple times in postpartum people because I did a neuro screen.
Okay.
So
Okay. Cool.
the
Cool.
again, is it an immediate referral because they have incontinence? No, but because they have incontinence, I'm going to do this neuro screen. And then if I see something that looks sketchy on that, I'm still probably not going to send you to the ER, but I am going to suggest that you go have a consult with a neurologist and I'll help you find one or call one if you need me to. And we will still also work with you in therapy. So I'm not waiting for them to be cleared necessarily. I just want to rule that out so that
Sure.
they have the knowledge and the ability to get early treatment for that if they choose to do so. But
Sure.
even with the presence of, let's say, known MS or known Parkinson's, pelvic floor rehab can still help with their symptoms. So, again, it's not something that I need to clear them of that medical issue. Often, what I find myself doing is actually treating in concurrence, if you will, with other healthcare providers. So, it often becomes a very multidisciplinary effort.
Yeah, and that makes sense to me. So now it seems like we've talked a lot of gray flags because it doesn't
Yeah.
sound like there are many red flags. So let's get into the things that they're going to tell you that are going to help you kind of itemize them because
Mhm.
there are many diagnoses like you said. There's a lot of GI related diagnoses that you may be able to help with pelvic floor. There's a lot of sexual related functions, a lot of continence and incontinence related things. What so I guess first off, what are the buckets?
Mhm.
Because like if someone comes in with shoulder pain, like in my head, I'm like, there are buckets.
Mhm.
And there can be multiple diagnoses that fall into the same kind of treatment bucket. And
Yep.
obviously we're going to address the patient's specific limitations,
Certainly.
but there are always these kind of general directions like do we need to work on that, do we need to work on this or the other. So would you kind of break down before we talk about the kind of conversation piece, what are these kind of primary buckets? Are some of them motor control and issues of the pelvic floor specifically? Are some of them more like core, like abdomen and low back muscle related? Are any of them joint mobility related? Like I'm just curious if you could kind of break down these buckets that we're going to kind of aim for, and
Mhm.
then we'll talk about how to decide which one they'll fall in.
Absolutely. So I am now going to introduce some bias because I am a human with a human brain and I have some bias, as do
Absolutely.
we all. So my treatment bias is and always has been to try to do treatment based classification
That's
when it
perfect.
comes to diagnosing
Yeah,
patients.
that's perfect.
And that's from my orthopedic background. I'm sure, we're all well familiar with lumbar spine treatment based classification, et cetera. But I also, to some extent, I mean, is it an interesting academic exercise to try to nail down like exactly which thing, this or that or the it is. But at the end of the day, the reason, in my opinion, that we need to do things like differential diagnosis and putting people in the right buckets, to use your terminology, is so that we know what the most effective treatment for them is going to be, at least to start with. And then, of
Yeah,
course,
agreed.
as we all know, we then can sometimes go down a meandering path. But what's going to be our biggest bang for our buck to get started so that we can help our person hopefully improve quickly, get that buy-in, strengthen that therapeutic alliance, and then, then potentially move on to things that are harder. Because one thing that is challenging sometimes with pelvic floor treatment is that often I am heavily relying on my patients to make lifestyle changes in order
Okay.
to actually address some of their issues. And that's much easier for them to do if they've already experienced some level of, okay, this girl has some kind of a clue what she's talking about potentially.
Sure.
So,
Yeah, please tell
long
me.
long preamble, but the treatment
That's okay.
buckets generally that I like, if you want to zoom out to the 30,000-foot view, they fall into an overactive pelvic floor, an
Okay.
underactive pelvic floor, and a poorly coordinated pelvic floor. So kind of those three. And underneath those, we can then bucket out into presenting complaints. So all the things that we've been talking about up to this point, in my
Okay.
opinion, are symptoms, not diagnoses. So incontinence is a symptom.
Right.
Constipation is a symptom. Low back pain is a symptom.
Hmm.
That's not the cause. We're looking for the cause. And it's funny that you mentioned core, because the reason, so the 2018 study with the 95.3% of people have pelvic floor dysfunction, that did
Hmm.
not surprise any pelvic floor therapist even a little bit, because the pelvic floor is part of the core, actually. It's a
Absolutely.
really important part of the core. And so what's interesting to, or what was very interesting to me as an orthopedic therapist is, and I'm sure we've all had this, right? There was always a subset of patients, mostly with what was then mostly called SI joint pain and
Uh-huh.
chronic low back pain, that just either didn't really get all the way better, like they got better, but not all the way better. And then you just kind of discharge them because they plateau, or who get better in therapy. And then you're like, why is this dude on my schedule again 6 months later? And it's the same thing and it comes
Yeah.
right back.
Right.
Somewhat to my shame, I have to admit that I kind of jokingly called those people frequent flyers, and I was like, did you keep up with your home exercise program?" And I really thought that in a lot of ways I was putting the responsibility for them being back in there on them.
Yeah, you
And
thought it was their fault.
there was some shared responsibility there, because now what I have really come to believe is, if we help people with the entire driving piece, if you will, of their
Right.
problem,
Right. The whole
they
system.
right, they really should not have to be dependent on our magic set of 5 exercises. Do I
Hmm.
encourage them to stay mobile and active? Of course, 100%. But why in the heck did I ever think that my, like, you need to do piriformis stretches, clamshells, bridges, and side leg raises, or whatever it was? This is your exercise program. I don't know why I thought that that was the
Right.
magical cure that would prevent the issues from coming back, but sorry everyone, it's not, and it doesn't.
Well,
So,
right. And I'm amazed. So I agree with you. So for anyone listening, this is a big thing that I think all the people that have come on the podcast and we're really trying to pin down. Like, if you solve if you really get down to the root cause of why they were having issues in the first place, their symptoms should not come back the same. They may
without some kind of an instigate. Like, I always
sure.
tell my patients, if you have another baby, we might need to do a tune up. If you, I mean, heaven forbid, but if you slip and fall on the ice, because we live in Missouri and it ices, same thing. But it shouldn't just come back out of the clear blue sky.
Right. And I think it's the same for a lot of issues. Like, how many people have, you as a listener, or you, Jen, as a practicing PT, it's like, how many times do we have someone that's like, oh yeah, I've it's the same back pain I've always had for 20 years. They're like, I've been to
Mhm.
therapy 4 or 5 times and it always gets better. And they're like, no, therapy's been great. They're like, my symptoms go away. And then like a year and a half later, it comes back. And in their mind, they're convinced they got good PT. And, we're not saying they didn't, but something was missing.
Yes.
Some part of that system, it was partially addressed to where they felt better, but it wasn't completely addressed to where they were better. And so it leads to these patients being like, so how long am I going to have to do my PT exercises?
Yeah.
Or they come in and they're like, oh, well, I went to PT 10 years ago and I've been doing those exercises every day ever since. And you're like,
And I mean, I appreciate
ah,
the devotion.
sure, me too. Like I don't have that much commitment,
Same.
but for anyone, I mean, I'm committed enough, right? I'm married, but like really to that point, like we should be able to address the system as a whole, which may require more than you currently understand, as uncomfortable as that feels, to make sure these people, like you said, we fix the system so that their normal, healthy, active lifestyles will self-maintain what we have built.
Yep. And I got 2 more dirty little secrets or clinical pearls for you that this seems like a
Please.
perfect opportunity to drop. Number 1, if someone comes in and tells me what you just told me, that is that's almost like a red flag for me that says, I wonder what's going on with their pelvic floor.
Mhm.
Because they may have had excellent PT because the PT
Absolutely.
was using the tools in their toolbox. But I just know statistically, the tool that PT was least likely to have in their toolbox was addressing the pelvic floor. So
Sure.
I do not assess. I always screen the pelvic floor on all of my orthopedic patients who have lumbar
Okay.
spine pain, hips, pelvic girdle, etc. But I don't always fully assess it, just at least not early on, just kind of depending. That is actually an indicator for me to consider assessing it immediately.
Okay.
Especially the ones who tell me it gets better while I'm doing PT and then within a few weeks or months I'm right back where I started.
Sure.
That is almost diagnostic that there is a pelvic floor issue.
Okay.
Secret number 2, you do not have to be internally trained to assess the pelvic floor, or at
Oh,
least to screen it with quite a bit of accuracy. Now, please do not hear me saying that internal training and exams do not have a place. That is the furthest thing from the truth. There are multiple
absolutely.
diagnoses that straight up will not get better if they do not have access to that kind of care. But I have very, very big feelings, as I tell my children, about saying, "Oh, I'm not internally trained, so I'm going to pretend that that group of muscles doesn't exist." Or, I mean, not even individuals, but almost as a profession, we've been like, "Well, there are some things about that region of the body and that group of muscles that make us not super comfortable, so we're just going to pretend it's not there." Here's the thing,
Right.
if all you do is add what I call pelvic health informed exercise cueing to your exercises for your patients with low back pain, you are going to dramatically enhance your outcomes. If that's all
Ooh.
you do. If you can
Ooh, I'm
also add
excited.
in a little bit of screening so that you can say, oh, are we overactive, underactive, or poorly coordinated so that you have a little bit more information driving that cueing, even better. And
Sure.
I obviously have an internal exam and treatment skill set, and I'm extremely comfortable with it. I use it frequently. I teach it to others. So I have no hesitation or difficulty there. I don't pull it out on every patient either, though, because
Yeah.
not everyone needs it. Most male patients with pelvic floor dysfunction do not need an internal exam, even for things that are very, very pelvic floor driven.
Hmm.
A lot of my female patients with incontinence and pelvic organ prolapse don't necessarily need a ton of internal assessment and treatment. So I think there's this misnomer that, like, oh, only those people, those less than 10,000 people with the specialty training can do anything to help people who have some pelvic floor dysfunction. That is not true.
I'll be honest. I thought I fall into that category if I thought that was the case. Like I
Yep.
have, but again, this is why we have these conversations, and I'm real excited to get into this, and I hope everyone else listening is too. So we'll jump back to the buckets. I'll kind of recap where you were. We'll jump into the buckets. We'll go through kind of the subjective and how to align where what we're going to look at, and then I would really like to know how we do this screening, and we'll go through that process. So you said there are three primary buckets that
Mhm.
are the overarching categories. There is overactive pelvic floor, underactive pelvic floor, and poorly controlled or activation pattern pelvic
Yeah.
floor.
That one's more like a motor control category, is
Okay,
probably the best way to look at it.
got it. A motor control, underactive, overactive. And you said that things like constipation, back pain, erectile dysfunction, those are symptoms, those are not diagnoses. So, why don't we go with what are the diagnoses that are going to generally fall under overactive?
Yep. And I will tell you this with the caveat that you cannot diagnose based on the subjective alone,
Okay.
because almost all pelvic floor diagnoses can be driven by any of the 3 buckets. They're just most
Ah,
commonly driven by this one. Does that make sense?
yeah. Yes.
So I want to be
Good.
very careful that nobody hears what I'm about to say and goes, oh, my patient has incontinence. They definitely fall into this bucket. You must confirm that with your hands or by
Great.
watching your patient move or
Great.
whatever your methodology is. I like to call it that we're ruling up or ruling down, right? I've kind of moved away from the old language that I got in school, which was ruling in and ruling out.
Uh-huh.
Even with more straightforward diagnoses, I don't know. I'm like, mm, I've been real wrong before, like what you just said about the shoulder. And it's like, oh, turns out it's a C5 or dick, or turns out it's it's a labral tear or whatever. So now, really, what helps me is to think of, okay, everything I ask them, everything they tell me, every test I do, I'm increasing or decreasing my index of suspicion that they are in this bucket. But
Right.
I'm keeping an open mind because I definitely know that, okay, there's a lot of things pointing towards this bucket, but it actually could be this one over here. So if I'm
Okay.
not getting the response I want, this is something for consideration. Or if I'm not finding what I'm expecting on my exam,
Right.
need to add in these couple of tests.
Right.
So, all of that being said, often problems with the word pain in them fall into an overactive category. Not
Okay.
always, but often.
Okay.
Almost always when it comes to chronic pain. Okay, so
Okay.
we're talking about things like low back pain, hip pain, pelvic girdle pain, pain with penetration, pain with elimination, or sexual function would fall into that category as well a lot of the time. Um, so that is sort of where my brain goes with a lot of that. Now, here's the problem. People think, oh, my muscle is overactive. That means it's really, really strong because it's working all the time. Unfortunately, that is not what that means. It's actually not what it means anywhere in our body, but it's very, very evident in the pelvic floor. And
Yeah.
here's the reason why. I always like to explain this to people by saying, okay, people are listening, not watching.
No,
Um,
this will be a
can they
video
see too?
episode.
Okay,
Yeah.
so think about your biceps and
Okay.
your elbow. Sorry, I'm like, which way does my camera
No,
go?
that's okay.
If your range of motion is this, how much weight can you lift? So
Not a
15,
lot.
about 15 degrees, if for
Sure.
those who are
I'm
not seeing
assuming
the
not
video.
much.
Not a whole lot, right? Because every single muscle in our body has an ideal length tension ratio.
Mhm.
Our biceps is designed or optimized to function at 180 degrees, not 15 degrees. So
Mhm.
I have access to the most power and motor control and function from my biceps if I have all or at least most of its range of motion.
Sure.
That is also true of the pelvic floor. So my folks who have overactivity in their pelvic floor may have functionally very weak pelvic floors. And that can drive things like incontinence and pelvic organ prolapse, which I will more so suspect underactive pelvic floor with those diagnoses. But again, if I have someone who has low back pain and incontinence, or I have sexual dysfunction or sexual pain and incontinence, we may just be dealing with an overactive pelvic floor because it's functionally not able, it's holding up here and it's not able to activate anymore to support the organs and movement, if that makes sense.
Yes, I will try to recap it for anyone else who is also like, whoa. So it seems like overactive, we're thinking more pain, particularly long term.
Hmm.
Um, it is likely not tight, like simply because it's so dang strong. It could very likely be holding on to a shortened length tension relationship because that's the only way it can manage to do its job because of how weak it is functionally. And it looks like even though things like prolapse and you said one other diagnosis is
Incontinence.
and incontinence can be associated with underactive, we should think of overactive with those things if it presents with low back pain and incontinence, sexual dysfunction and incontinence. So it looks like overactive seems to be when there's pain involved for longer periods of time, along with other concomitant pain.
most of the time, with the
Most of the
caveat
time. Yeah,
that I may
most of the
say,
time.
"Oh, we're gonna bucket this in pain," and then later I realize, "Oh, no, this is" with my exam, I realize, "Oh, nope, actually, this is more so a motor control issue."
Sure.
Male sexual dysfunction is almost always an overactive pelvic floor issue because
Okay.
it is so tightly intertwined with blood flow, and the
Mm.
overactivity of the muscles is often restricting the blood flow.
Okay, great.
So
And so now moving, and for anyone listening, we are going to get into the nuances of the assessment and we'll talk about that stuff as we go along. But want to give you an idea. So what is our underactive bucket?
So our underactive bucket is what people, well, and some people still call it, and the literature sometimes calls it weakness in the pelvic floor.
Okay.
I don't like to call it that because I have yet to meet anyone actually who truly has a weak pelvic floor.
Okay.
I've met all the people in the world, at times including myself, who have very poor motor planning and very poor ability to proprioceptively and consciously control their pelvic floor and make it do what they want it to do.
Mhm.
But usually there's not a muscle bulk issue.
Okay.
Unless there's been a significant injury. I have not treated anyone with this, but there is an injury that can occur where part of the pelvic floor is actually disrupted or torn that can lead to true weakness. And so that is certainly a possibility. I'm not saying it never happens, but barring that or some kind of a neurologic diagnosis, it's unlikely that their pelvic floor is truly weak. It's usually a
Okay.
proprioceptive issue. So I like to say, well, their pelvic floor is either underactive
Mhm.
or poorly coordinated, meaning, well, if I sit there and ask them to isolate and activate their pelvic floor, aka do a Kegel, they can do it just fine. But then I watch them move and I'm like, that motor pattern doesn't look good. And maybe we're having leaking when we squat at CrossFit or whatever the case may be.
Okay.
Well, if we're having that issue, I know their pelvic floor is not doing its thing the way that it's supposed to. But if they can isolate it and activate it just fine, that means that we have a motor control issue. Now, if
Mm.
they cannot isolate it when we do just the Kegel, and they're like, I don't know, they're either doing the reverse of a Kegel, so they're actually elongating their pelvic floor when they're trying to activate it, or they're just not doing anything at all with it. That to me is the underactive pelvic floor, which again is a proprioceptive issue 99% of the time. But so what I'm saying is that the underactive and the motor control issues are kind of the same symptoms, and you
Yeah.
differentiate between them based upon can we isolate or can we not isolate. Does that
Okay.
make
And
sense?
yeah, and if you can isolate, so I'm sitting here and I squeeze that pelvic floor. I do a Kegel, but then you see me move and you're like, ugh, something's off. That's more motor control. And
We
then
don't
if
know
you're
how to use it with all the other muscles because
right,
in real life, we can talk about this later, but Kegels are the least effective way to strengthen your pelvic floor because they don't mimic anything that the pelvic floor does in real life. The pelvic floor never activates by itself in real life. So that
right.
motor control piece is really important because it has to not just do its thing by itself, but also work with all these teammates. And that's often something that is not happening optimally.
Right. It gets lost in the sauce, so to speak.
Absolutely. Yep.
So if they can isolate the pelvic floor, then but it's not interacting with the rest of the body during activity, we're looking at motor control.
hmm
And if they cannot isolate it or they're elongating it, they're just really having a hard time activating it, period, we're looking more underactive.
Yep. And
Okay.
most of the time, but not always,
Yeah. Yeah.
those symptoms are going to be things like incontinence. They're going to be things like I have a lot of pain, but it's not that like chronic non-specific pain. It's usually more pain with transitions. So like your patients who are like, I mean, I've got some pain all the time, but when it really bothers me is when I go to get up out of a chair. That's more
Okay.
likely to be one of those 2 categories. Pelvic organ prolapse is one I didn't talk about too much before, but that one would also often fall into that category. But
Okay.
all of those things can be caused by overactivity, and all of the things in overactivity, for the most part, can be caused by the underactive or the motor control. So you really do have to rely on your exam
Okay.
in large part.
Great. So I think for anyone listening, they're like, "Well, tell me how to do it." So, so let's. Um, I don't do pelvic health, so in my head, I'll kind of delineate kind of the order I would think. And if you're like, Nate, that order sucks, you can tell me whatever order you screen and assess in your way. I would assume, because in my mind, screen is more superficial before like more in-depth assessments. And you had brought up a couple things. You brought up screening the pelvic floor for both pelvic health issues and orthopedic issues, which I look forward to learning so I can start using this.
I was gonna say,
Um,
you're gonna start doing some pelvic health
oh,
after night.
oh, I can't wait. And then secondly, you brought up a neurological exam to screen those potential gray flags. And again, not because you won't treat them or that you won't be able to treat them until they're cleared, but just so you may get them in contact with the appropriate other healthcare professionals, since the pelvis can be multifactorial.
Mhm.
So, I'll just shut up. You kind of go through your things. I think people would really like to know, how do you screen the pelvic floor as a non-pelvic floor credentialed therapist,
Mhm.
and then the neurological testing for the pelvic floor, and then I'll kind of ask questions as needed.
Cool. Okay. So every great evaluation starts with a wonderful subjective exam, right? So we
Yes.
start there. Hopefully, everyone's really comfortable there. What I would recommend adding in to your assessment, if you are not a pelvic floor specific therapist, so you're not necessarily advertising yourself as come see me if you have incontinence or you're having problems after you have a baby,
Hmm.
etc. What I would add to your intake questionnaire or to the questions that you ask, however you'd like to do it, are you having any issues with unintentional leakage of urine? And please do not ask them if they're having incontinence, because all the people think that it only counts as incontinence if they're standing in a puddle. And then, but if you're like, okay, but do you ever have just a little bit of leakage, even if it's a small amount? They're like, oh, yeah, that happens all the time. That's incontinence. I care about it because if you're experiencing that, that tells me the system is not working correctly. And
Hmm.
then I want to know, when does that happen? Does it happen with high pressure movements like jumping, coughing, sneezing, laughing? That has me thinking, okay, we probably have a motor control issue here. Because if it was
Okay.
an underactive pelvic floor, it would happen with less less stress needed, if that makes
Okay.
sense. So
Okay.
if they're like, yeah, I have it when I sneeze and cough, but it also happens when I stand up out of a chair, now we're probably talking underactive. Does that make sense?
Yeah.
So any
Yes.
yeah,
So
any urine.
motor control is when it happens with more involved things, running,
Mhm.
jumping,
Higher level.
coughing, higher in like more intensity, more abdominal pressure
Yes,
based
more
things.
intra-abdominal pressure.
And so those would be more motor control. But as soon as they bring up something that is not like high impact or high pressure, like, oh, I go to stand up, I go to do something relatively low intensity, and there's leakage, then it's pointing you potentially to underactive.
Right. It's
Okay.
it's increasing my index of suspicion for that.
Okay. Got it.
So, any urine leakage, no matter how small, that's unintentional, ever.
Okay.
I want to know
Got it.
about that. Do you ever have difficulty starting or completing either a bowel movement or urination, so going to the bathroom? And then,
Okay.
do you have any issues or difficulty with sexual function of any kind? Okay, those are the three questions.
Okay.
Now, every single time, so I teach an entire lab course that is just on how to assess and treat the pelvic floor with no clothing off and no internal skills necessary.
Okay.
Every single class, people raise their hand, and I also had this thought burning in my mind as I was taking my first course. Jen, what in the world are people going to think when they come in to see me for low back pain and hip pain and I start asking them if they pee their pants? And I get it. I was there. I was
Mhm.
worried about that too. What I will tell you is I have been doing pelvic health in some capacity since 2012,
Mhm.
but I started doing it as kind of a side thing. So it wasn't a large, most of my practice was still orthopedic, and I did a little pelvic health. And then as things progressed, I eventually got to where most of my schedule is pelvic health, but I've always
Mhm.
continued to keep some orthopedic caseload also. And I think pelvic health is a subset of orthopedics, but that's a whole other conversation. That being said, So I've had this conversation many times with people who have come in for not kind of stereotypical pelvic health diagnoses. Never one single time has anybody had any hesitation when I ask them those questions. Not
Okay.
if they are a very different person from me, not if they're a very different age from me, not if they're the opposite gender or sexuality,
Hmm.
nothing.
Got it.
Actually, what happens is that they are very grateful and almost excited to talk to a healthcare provider who has some kind of knowledge about this issue that has been plaguing them for insert terribly long amount of time here a lot of times.
Right.
They actually did a very interesting study of primary care providers, and they found that patients often don't ask their PCPs about sexual function or bathroom issues, not because they're embarrassed, not because the patient's embarrassed, because they're worried the healthcare provider will be embarrassed. So,
Mm.
between that and the inherent power imbalance that just exists because they're coming into your clinic, you're not going into their home, I think it is really our responsibility to set a comfortable tone to have these conversations. And your patient will probably mirror you. They'll probably be about as comfortable as you project yourself to be. So just to
Sure.
throw that out there. That said, a really easy way to do it if you're not at the point yet where you can just spit it out, no big deal, which can take some practice and some time. Like, again, I've been doing this since 2012. Doesn't
Sure.
phase me at this point, but it did at one point.
Hmm.
Just put it on. Most places have people fill out just like a review of systems of some sort, right? That's where you ask about things like unexplained weight loss. Just put
Hmm.
those items on there. And if they circle them or underline them or check the box or however you have people do that, that opens the door then for you to say, "Oh, hey, I noticed that you circled that you have a little bit of urine incontinence sometimes. Can you tell me a little bit about that? I know it doesn't necessarily seem super related, but actually the muscles that control that are very involved in helping your body function and supporting your low back. So it would help me
Yeah.
a lot to really understand a little bit more detail about what's happening." And it
Hmm.
turns that into just a very smooth transition. So
Yeah.
that's the switch I would make to your subjective. I will say too, when it comes to constipation, there's a really cool tool out there, and you can just Google this. Nothing weird will come up, I promise. But you can just, well, I sometimes am like, I wonder what the guy sitting next to me on the airplane thinks when I'm on my way to my courses. So, you know, but if you Google Bristol stool scale and then look at the Google images, there are a bunch that'll show up. It's just a very simple little image that you can easily put again onto an intake form. I just ask people to mark what kind of stool they're having because unless you
Hmm.
recently had a baby, like unless you're within 2 years of having had a baby, you probably don't regularly see anyone's poop except yours,
Right.
right?
Right.
So many of us don't really have a concept of what normal or good stool looks like. So
Yeah.
it's not as simple. You can't just be like, "So, are you constipated?" Because your patient may be like, "Oh no, I'm not constipated. I have bowel movements 3 times a day." But then
Yeah.
if they point on the Bristol stool scale to the ones that look like little tiny rabbit pellets, that is someone who is severely constipated. People who are constipated sometimes poop every day. That does not mean their stool is moving the way that it should. So
Yeah.
that's a little thing that I find very helpful to either just add to your intake form or have in your room or on your clipboard or someplace where you can use that as part of your subjective. There
Great.
are some other questions that can help, things like if the person potentially has ever been pregnant. Have you ever been pregnant? Have you had babies? If you've had babies, were they vaginal deliveries? Were they cesarean sections? Have you ever had an abdominal surgery? I never used to ask people that. Please ask people if they've had an abdominal surgery. Patients have had gnarly procedures sometimes in their abdomen, and I don't know why, but it's like the abdomen is the final frontier of surgical medicine. We don't send people for rehab after we cut their core open for some reason. We don't
Yeah.
do it after liver transplants. We don't do it after C-sections. We don't do it after laparoscopic procedures where we create a nice little tunnel for scar tissue to grow down and, stick things together near the organs. And
Yeah.
so if they've had a procedure in their abdomen, it's probably important to know, even if they're coming in for hip pain. So
Okay. So
again,
yeah, I have a few questions. So
yeah.
so if someone gets pregnant,
Mhm.
but maybe they have a miscarriage, maybe they have an abortion, i- um, so we still like, how is that going to, well, I guess that could be its own conversation. So maybe we'll have to table that for another time. But I guess what if someone says they have a C-section or
Mhm.
they've had 4 vaginal births or they were pregnant but did not have a child,
Yep.
or I have a patient currently who had a fusion where they did
Yep.
a posterior and anterior approach, and she's got a gnarly scar next to her C-section, which
Mhm.
she never got therapy for.
No.
Um,
Yeah.
so what exactly do any of those give me any, like, what information do I need to, so if they say I was pregnant but I didn't have a child,
Mhm.
what does that actually give me?
Absolutely. And just a simple we could probably talk for a whole podcast on reproductive stuff, and I'd be happy to
Sure.
do that. But
Sure.
just to give your listeners something very simple, usually what I do is I just have on my intake form number of times pregnant, number of vaginal deliveries, number of C-sections, and just
Okay.
leave it at that. And then you can math. And if the math doesn't add, then that does mean that they had either an abortion
Oh, right.
or a miscarriage. And that way you don't necessarily have to directly ask them because those can obviously be very painful topics.
Oh,
And
sure.
having had an abortion or like an early miscarriage or an abortion most of the time is not going to affect the evaluation or treatment for your patients with more orthopedic conditions. Now, if
Got
you're
it.
treating something where you are doing internal work and you're working with the uterus and some of those things, it can. And so, again, that's kind of a different pathway. But I think for the majority of your listeners, mostly what they are going to want to know is there scar tissue from a C section? And did they have
Got
a
it.
vaginal delivery? Because a vaginal delivery does not doom you to and pregnancy doesn't doom you either to having pelvic floor dysfunction, but it does increase your likelihood. There's a statistical relationship. It's not a causation, it's a correlation, but it's there for sure.
Got it.
So the scar tissue
Uh-huh.
impacts how people use their abdomens and how they use their diaphragms. The
Okay.
pelvic floor and the diaphragm move together. So
Uh-huh.
when your diaphragm drops, so does your pelvic floor. When your
Mhm.
diaphragm rises, so does your pelvic floor. You can
Yes.
use this to cheat in both evaluation and treatment, which we'll talk about, I'm sure.
Okay.
But if you have scar tissue in the abdomen, that may restrict the ability of one or both of those to move, not necessarily always even because of the scar tissue itself, but because the body develops guarding around the scar tissue. Now,
Right.
this starts to dive a little bit into pain science, and I always say that pelvic health is about half pain science and about half orthopedics. Really, honestly, it is. Um, but what you need to understand is that your body will guard and will protect an area that has been traumatized. And a surgery is a trauma, period, the end. Even
Right.
if it was one that was done with your consent, that you wanted, that you fully understood, your frontal lobe knows that it was fine. The part of your brain that controls whether your muscles guard or not doesn't know it was fine and doesn't believe your frontal lobe even a little bit. And think about what's in your abdomen. Like, what's in there? Your vital organs. So, your brain really protects your abdomen. And unfortunately, with a cesarean section, again, even if it's an elective cesarean section, you went in and you asked for the C section. Again, if you go to that part of your brain that controls whether or not you guard from the perspective of that part of your brain, somebody opened your abdomen and took your gestating baby out of it. It doesn't get a whole lot more traumatic than that from a, like, purely because that part of our brain works on a very kind of I hate to say animalistic, but it's very much just, like, very simple. It's not any kind of reasoning at all. It's just all reflexes, essentially.
Right.
So people tend to guard the living daylights out of this any scar tissue that's in the abdomen, which then causes them to squeeze their abdominal muscles, kind of hunch in. That impacts how they tilt their pelvis. It impacts how they breathe. It impacts how they move.
Right.
So,
So that answers my question, because it doesn't seem that we get anything specific from knowing if they had cesarean, vaginal births, pregnancies. It essentially, it starts racking up how much trauma has this abdomen or vaginal canal or pelvic floor, how much trauma has it experienced, and how much likely either guarding or protecting around potential scar tissue could be present. And
yes.
for
Do
and
I
for
need
anyone,
to check their abdominal mobility? Because
I
if
will
they
actually.
have no reason to guard in their abdomen, I'm probably not going to worry too much about their abdominal mobility.
Right.
But if they've had a C-section, I will.
Oh, okay. And so for anyone listening, what I realized, so we know that scar tissue, the statistic I was told is scar tissue is 70% as strong as normal healthy tissue. Um, that's what I was told. I don't know if someone's going to fact check me. You're welcome to do that. If I'm wrong, we'll fix it. But
I think that's such a hard thing to measure because they measure that on cadavers, which
right,
how do you pronounce that? Cadaveric
cadaveric.
tissue does not function the same way as living tissue. So I don't actually think we know the
Fair
answer to
enough.
that question, but we know it doesn't move as well, which is
Right.
mostly what I'm interested in.
Right. And if something does not move as well, like you said, there is an underlying system in the brain that says, don't overload this section.
Hmm.
And so it will protect it and it will not want to load that section normally, which can predispose everything around it to either getting overloaded or under firing because the body doesn't want to do anything around that. So that was just kind of my takeaway from that.
Hmm.
And it sounds like pregnancies, traumas, anything around the abdomen, surgeries. It's more just, again, like you said, it's either ruling up how much trauma has this abdomen, this pelvic floor experienced and has been managing for X amount of time.
Hmm.
Oh, okay, got it.
Yeah.
So how do we screen it? And I have no idea how to test abdominal mobility, so
Yeah,
I'd
most
love to hear
people don't.
about that. Okay, yeah, great.
Yeah. No, and it's so funny because now I check all the abdomens and I never touched anyone's abdomen ever until I did my pelvic floor training, and now I check it on absolutely everyone. So I'm just laughing because I'm like, it's so funny how it's turned into such a major part of my practice pattern when I literally did it never before.
Right.
But we learn more and then we adapt our patterns accordingly, right? So that's
Mhm.
what this podcast is about.
Correct.
So, to screen for abdominal mobility, it's actually pretty easy, and you do actually know how to do it. You just haven't done it in the abdomen.
Okay.
So, what I like to do first is I like to just screen for global mobility. So, I
Okay.
just put my hand flat in the middle of their tummy, like typically just slight, like to where this part of my hand is just slightly above or at the level of the belly button, and then my fingers are pointing up towards their head.
Okay.
So I'm just resting my hand on their belly.
Okay.
And then I just actually have them breathe for a minute and I'm just feeling and noticing like does their whole belly move when they breathe? Are they holding
Mm.
their whole belly still and not really moving at all when they breathe? Or often what I'll feel is okay, this part maybe the upper part is moving fine, but there seems like there's some hesitation to movement in other regions. So I can
Okay.
do that. That's more of like a functional movement assessment. And
Okay.
then what I like to do is just move my hand around. So, and this sounds terribly unscientific, but that's how soft tissue assessment and treatment kind of is.
Yeah.
Unfortunately, sorry, it's just kind of how it goes. But what I like to do is I like to go up and down. So, like towards the head, towards the pelvic bone, or towards the feet. And really, what I'm feeling for is does it feel like there is a restriction or a guarding to movement? When I say guarding, what I mean is if I move this way, do they kind of clench a little bit and guard a little bit more? Okay, interesting. There might be something lower near their pelvis that I need to know about or I need to assess in more detail. And then
Okay.
I also like to go side to side, so just left to right, kind of
Okay.
feeling for the same thing. Then I do diagonals, so up and to the side, up and to the side, again, just feeling for is there restriction. And then the other movement in the abdomen is actually side bending. So I'll just leave it there and almost like twist or rotate.
Okay.
And again,
So
I'm just feeling for do any of those motions re- elicit a guarding response? And do I feel like there's a direction that they just subconsciously don't want me to go?
okay. So just quick just detail. So the base of the palm is on the belly button.
Hmm.
The fingers are up towards the ribs, and you are laying it on their stomach.
Yep.
Um, this is just a quick yes no question. This isn't my actual question. Do you prefer if you're touching skin or shirt?
It can be done through the shirt. It's probably more accurate not through the shirt, but I am okay with screening through the shirt
Okay.
unless I have someone who just, I mean, sometimes people are just like, it's fine, just, pull their shirt up and then that's fine too.
Okay. Got it.
If there is an actual scar to assess, so let's say we did have your patient who had the C-section scar and the kind of bilateral approach scar, or not bilateral, but anterior and posterior approach
Mhm.
scar. I do like to assess those not through clothing. And you
Got it.
just assess those the way you assess any scar anywhere in the body. Does it move? Is it uncomfortable? Is it numb? All the things. So it's really not any different from assessing the scar after a total knee replacement. Again, just a different part of the body.
Got it. So my second question, and this is my real question. So when you say you're moving the hand,
Mhm.
meaning are you leaving it on the abdomen and you are dragging it,
Yes.
or you are picking up the hand, putting it lower on the abdomen and having them breathe?
Oh, no, no. Yeah, so I'm sitting there. Oh, sorry. I'm, like, not good with facial awareness. I'm sitting there, and then I'm leaving my hand where it is and doing movement with it
Right. So you are
to see how
you
the skin glides.
yeah, you are taking that skin and you are gliding it without taking pressure off. You're gliding it up, gliding it down, gliding it left, gliding it right, gliding it diagonally, and then also kind of turning it to see if any of those make them kind of either unconsciously tighten up or facial expressions or response, and
Yep,
just seeing how everything moves.
yep.
Okay, great. Just wanted to clarify that. So I'm ready for more.
Perfect. So that's it. That's how I assess the abdomen.
Oh,
I
okay.
might have them do a little bit of a TA contraction, although I actually like to save that for when I'm screening the pelvic floor because then I can look at them both at the same time. And so yeah, that's it. I usually do so in if we're talking about like order of events when I'm assessing someone, subjective comes first.
Got it.
Then I like 30,000 foot and then zoom in. That's just my
Sure.
personal preference. I think you can do it other ways. But so then I will do any kind of system screening that I feel like I need to do. So I might do a neuro screen. I might do a cardiac screen,
Okay.
just depending on what the patient told me.
Right. And for anyone who may be less familiar, because we
Mhm.
oftentimes when we get into just our world of just cruising, rocking, trying to get all my notes done and not die,
Yeah.
um, I'm gonna be honest, I'm not sure I could concisely describe a neuro screen
Oh,
or a
sure.
cardio screen. Could you go through those?
Yeah, absolutely. So a neuro screen for me, again, this is someone that I'm actually trying to rule out, is there a neurological component because they said something that made me concerned or they presented in some way that made me concerned. So I
Yeah.
check reflexes. I usually check patellar tendon reflex and biceps reflex. I
Okay.
don't usually bother with the Achilles reflex, but I mean, there's nothing wrong with including it. I just usually don't.
So you do
Um,
full systemic
uh,
screening of neuro, not just lower quarter.
Correct, because
Got it.
this is if it is neurologically driven, it's usually a central nervous system issue, not a peripheral nervous system issue. There
Got it.
could be
Okay.
peripheral nervous system issue, but that's very rare. It's most commonly central.
Got it.
And then I'll have them walk, which I look at a lot of things when I'm walking, but this is one of them. So I'll have
Okay.
them do just like normal walking, and then I'll have them do toe and heel walking. And then I also like to have people do tandem walking. And this is neuroscreen, but I am also watching quality of movement. So what does our balance look like? What does our movement strategy look like? So I'm extracting a lot of information from some of these. It's not
Got it.
just a neuro screen. So just wanted to throw that out there. Which, if you're a new grad and you don't feel like you can do that, it's totally okay to have your patient walk multiple times. And I absolutely did that for a long time. And even when I was kind of getting into pelvic, I did a lot of things one at a time that I can now do simultaneously. So wherever you
Mhm.
are on that learning journey, it's completely fine. That's just where I am now.
Sure.
And then from there, I do myotomes. I don't actually usually bother with dermatomes unless I think that they might have a cauda equina, which I have had patients with known and unknown cauda equina.
Okay.
Pelvic floor therapy is actually a version of treatment for cauda equina alongside of some other things, of course, and medical treatment. Um, so yeah, I usually skip dermatomes, but I do myotomes head to toe.
Okay, got it. So yeah, full screen. Got it.
Yep. And I
Um,
also do a cranial nerve screen, which
oh
I had to
wow.
reteach myself that
Yeah.
because I hadn't done it in a hot minute because I'd been in outpatient ortho. But it doesn't take very long once you reteach it. But again, we're looking for a central nervous system issue, and it's not uncommon for it to be like, oh man, young, healthy person just had a baby, failed that nerve test or the cranial nerve screen. And I send that information over to the doctor, and I'm like, I think we might have MS. And I've actually caught MS really frequently in people, and in younger
Mm,
people than you think, people in their 30s and 40s. But
okay.
if you catch it that soon, you can prevent it from being at all symptomatic for often a very long time. So
Oh,
that's the good news of that.
great. And so you also mentioned, was that the end of the neuro screen?
Yes.
Okay, so you also mentioned, particularly for men with ED,
Mhm.
a cardiac screen. How are
Yes.
you doing that?
Blood pressure
Okay.
and heart rate.
Okay.
That's
So
all that I have the equipment to do. I have no EKGs in my office or anything like that. But a
got it.
lot of times their blood pressure is suboptimal. And I'm like, how long has it been since you had a physical? And they're like, oh, girl, 20 years. And I'm like, it might be time. So
Okay. So what types of blood pressures are concerning? Is it both high and low? Is it more high?
I'm more so looking for high, and I
Okay.
mean, they've actually changed the criteria now to like I learned 120 over 80. Now it's really like in the 110 to 130 range is considered pre-hypertensive and something to watch, not necessarily something to
Hmm,
medicate, but something
okay.
to watch. But if they're even in that 110 to 130 over 80-ish range or higher, I would like them to be actually cardiac screened by someone who can do an EKG and some other more specific testing that I do not have access to as a physical therapist.
Got it. So you're essentially looking at anything that would be considered pre-hypertension or hypertension.
Yep.
Got it. And what about heart rate? Are you looking for abnormally high heart rates, like over 80?
Yes.
Oh,
Yes.
okay.
Yep.
Okay. Is it over 80? Was that just a good guess?
So it's over 90 usually
Over
for me
90.
to be concerned. But yes,
Okay.
I'm looking again on the high end. Low end, I'm not usually worried about unless they're complaining of dizziness or something like that.
Okay. Got it. Okay. Perfect.
Yeah.
Okay. I
So those are the
continue.
systemic screenings that we'll do. I will sometimes check temperature, not really commonly, but if because we touch our patients, right? So if I'm touching their skin and I notice that they may have a temperature, I do have the ability to do that. And if they're running a fever, I'll ask them, hey, do you feel like you're ill? Because sometimes people do have fevers that come and go that can be again concerning for something that's a little bit more serious than just a musculoskeletal condition. From
Okay.
there, I like to move into my functional movement assessment. So I
Okay.
already watched them walk. So I don't need to do that again. Again, if you need to for where you are in your clinical journey, totally fine. I
Mhm.
also generally like to watch people squat and or get up and down from a chair depending on what their physical abilities and activity levels are. And I also usually like to try to watch people go up a curb or up a step.
Okay.
What I'm looking for with these, and
Yeah.
here's where I said breathing is a great cheat. I am looking to see, does my patient do anything wonky? That's the technical term.
Mhm.
Do they do anything wonky when they go upstairs or when they squat or when they stand up out of a chair?
Okay.
How many of us at some point in our evals and or more commonly during our treatments ask our patients to quit holding their breaths?
Oh, all the time. I
All the
find it all
time.
the time.
Yeah, multiple times a session for a lot of people. Holding your breath is almost diagnostic. No, I would say I'll go a step further. It is diagnostic that your pelvic floor is either underactive or poorly coordinated.
Hmm. Okay.
Period. The end.
Okay.
Because holding your breath makes your diaphragm stop moving. That is a way to increase your intra-abdominal pressure to support your skeletal system, which we
Mm.
now know is how our skeletal system is supported. I don't think it's a particularly functional way because we can't live our life holding our breath, but it's a way to accomplish that. And our bodies are really, really good at figuring out how to accomplish things if we can't do it the right way, if that makes sense.
Yeah.
And so if you see someone holding their breath, especially with movements that are harder for them. So for this person, it may be standing up out of a chair. Little secret for y'all. Those patients who say they have pain when they get up out of a chair or they leak when they get up out of a chair, that's the only time they leak for a lot of my patients. Have them exhale as they stand up. That will fix it about 99% of the time. And you never touch
Hmm.
their pelvic floor. Just
Hmm.
exhale while you stand up instead of holding your breath and doing a
Okay.
Valsalva, which is what they're doing. But yeah, so I'm watching for, are they holding their breath? Are they doing some other kind, like we're watching generally for aberrant movement patterns. We're doing that here too. So the muscles at play for the core are the diaphragm, pelvic floor, abdominal muscles, and then the spine stabilizers in the back. Do
Mhm.
they look like they are overly dependent on any of those? So, your back pain patients who feel like they've got steel cables running up and down their back and they're like really into those erector spinae muscles, man, those things are well developed. They could be on like an erector spinae catalog. Those people usually also have poorly coordinated pelvic floors. And again,
Mm.
their body has figured out a different system to rely on. The problem is, so all of these systems are okay, by the way. Our body is made to do this
Right.
short term if we're
Right.
recovering from injury or we're at the end of our pregnancy and we need that extra support from some of these structures, or we just had a C-section and we need to give our abdomen and our pelvic floor a break. So it's not a problem that these systems do this. It becomes a problem if that then turns into our default motor pattern over a period of time. So that's what I'm looking for in my functional assessment. Now,
Okay.
I decide what regions of the body I want to assess in detail, usually dependent on my functional movement assessment and their
Okay.
presenting pattern. So I generally screen spine, hips, and pelvis on pretty much everybody, but how much detail do I go into? Do I do a full, like, am I doing a detailed joint mobility assessment or am I really just doing range of motion overpressure? Really just depends on what I saw. Many of our patients with pelvic floor issues have significant limitations in hip rotation, especially a lot of our male patients. And so that is something I always want to look at. There's a
Okay.
muscle,
Is it more hip? Is it more internal, external, or both rotations?
mostly internal. And the reason why, and they usually have excessive external rotation actually. It's like they won't
Okay.
move at all past neutral into internal rotation. And then they've got like 90 degrees of external rotation is the pattern that I see.
Oh, okay. That's me to a T.
I was going to say,
Um,
you met any individuals like that?
so I guess for anyone wondering, are you assessing that in a supine 90-90 position?
Usually, yeah.
Okay, got it.
That's just
Perfect.
easier for me because 'cause I'm getting old and lazy. Um, so,
Sure.
yeah, and the reason why is there's a little muscle, little tiny muscle that causes a lot of problems. Its name is obturator internus. It's a
Okay.
hip external rotator muscle, but it's one of the only muscles in our body that attaches to only muscle and fascia on the other end. It does not attach bone to bone. I never learned about this
Hmm.
muscle in PT school, by the way, but it attaches into the pelvic floor.
Oh,
So
fascinating.
when the obturator internus is shortened, which it often is, it pulls on the pelvic floor and makes it very hard for that pelvic floor to do its job.
Okay.
So
Got it.
that's why we're looking at hip rotation. And then, of course, spine and pelvis. Again, I just want to know how they're moving. And whatever normal assessment you would do there based on your patient's presenting complaints is probably what I would do there, to be
Sh-
honest with you.
Sure. So if I could, Jen, I'll tell you what I do.
Yeah.
Because I feel like I do a pretty thorough around the hips. Like I oftentimes will look at like a fader motion. So I do like a
Mhm.
scour. I
Yep.
look at internal external rotation in 90-90. I do horizontal adduction. Sometimes I'll get the leg down and I'll do abduction. I'll put my hands on the ASIS and I'll kind of rock the pelvis, see how it moves. And I'll do like straight leg raise tests, stuff like that. Is there anything that I may have missed that you include?
Not unless one of those makes me wanna go down a rabbit trail. So,
Got it.
sometimes
Got it.
we'll have findings and we'll go, "Oh, I wanna look a little bit more closely at that." But as far
Sure.
as a general screening, yes,
Okay.
that's more or less what I do. Yep.
Okay, great.
So then the other thing that I like to screen that probably is a little bit different or not in people's typical practice patterns is I like to actually screen the pelvic floor by palpating it with people's
Okay.
clothes on.
Okay.
And before anyone panics on me, you can palpate the pelvic floor without getting really that close to the genitals, actually. And
Okay.
I don't personally think it's any more invasive than palpating the piriformis, which most of us don't really hesitate to do.
Sure.
Now, obviously, you're getting your patient's permission, you're explaining what you're going to do. And if they say no, then I'm not going to do it. But it can give you really helpful information. So, the way that you find it is you get your hand and you put it on the ischial tuberosity. Or
Got it.
around here, they call it the sit bone. So I'll tell my patients the sit bone. But you put it
Okay.
on the ischial tuberosity. So let's pretend, again, I'm going to have the camera issue probably. Let's pretend this is my ischial tuberosity. Okay.
Okay.
The end of it, or the part that's most towards the feet, if you will. So I'm going to palpate that and then I'm going to put my fingers kind of flat on it right about here. So right around that kind of middle region of my fingers. Then I'm not moving my hand. I'm just going around the corner and palpating the medial aspect of that ischial tuberosity.
Okay.
That puts your fingers on the pelvic floor. That's
Okay.
all you have to do.
Okay.
It takes a little practice because many of us haven't traditionally palpated here, but that puts you nowhere near the rectum, nowhere near anyone's genitals. You're not going to run into anything that you don't intend to run into. Okay. The
Okay.
tips of your fingers will be on the pelvic floor. There are also components of the pelvic floor that do attach right there on that medial aspect, but mostly what you're going to be feeling is what's on the tips of your fingers.
Okay.
Once I'm here, so I do this on both sides. I usually sit on their side and then switch sides of the table. That's just easiest again on my body. What
Okay.
I'm feeling for is this tender for you at all? If it
Hmm.
is tender and like, sorry guys, you know what tight muscles feel like. If it feels tight, it is tight. It's overactive.
Got it.
Um, and if it's uncomfortable, it's probably also overactive. That's not diagnostic, but it's highly suspicious.
Okay.
And then we check it on the other side, and you're looking for symmetry too. The pelvic floor likes symmetry. If you've got one side that's not matched by the other side, that often will cause a problem. And in fact, it's one of the most common causes of that pelvic girdle pain that comes and goes that doesn't respond to normal PT or doesn't stay better. Often on that same side, there's a one-sided overactivity or spasm of the pelvic floor that's not answered by the other side. So they've
Hmm.
got kind of this constant pulling on that joint basically, and they're increasing their pressure there.
Okay. Okay. So if I'm doing that, if I'm palpating,
Mhm.
am I having them do anything specific? Are they just breathing? Am I having them tighten it? Like,
Yep.
what are they doing while I'm palpating that?
Yep, so I find it, and at first I'm just like, "Hey, how does this feel? Any discomfort or anything like that?" And then I'm noticing what does the quality of the tissue feel like. Then I like to do a little bit of a functional movement assessment, so I do ask them to take some deep breaths. What I want to feel is that when they inhale, I get a little bit more pressure on my fingers, and as they exhale, that pressure lightens. This is very subtle, it's not a big movement, but
Okay.
if you focus and practice, you can get to where you should be able to feel that tissue drop into your hands and pull away. What's
Okay.
more common though is that you will feel it not moving. If you feel like
Okay.
it's not moving, they're probably not moving it, which means that we have some work to do with regards to mobility, possibly of both the diaphragm and the pelvic floor.
Okay. So
Okay.
if it's not moving, does that go into an overactive category?
Yes.
Okay.
Almost
Got it.
certainly. Yep.
Got it.
Because
Just double checking.
they're holding everything. They're guarding, if you will.
Got it.
So then I also like to have them cough or sneeze, especially if they told me that they leak when they cough or sneeze, because I want to see what happens there. Much of the time, what happens is they go to cough or sneeze, and what should happen just automatically without us even thinking about it is our pelvic floor should pre-tense and then do a big tense when we actually cough or sneeze because we should be generating that pressure from the bottom up to push that air out of our lungs.
Okay.
But what often does happen is that we don't get that pretension and instead we expand our pelvic floor or we elongate or lengthen our pelvic floor when we're coughing or sneezing and we're going to go to the point of least resistance and that's going to cause that urine to come out because we don't have the support from that pelvic floor lifting.
Got
So
it.
I want to see what happens there. And again, what I will feel, I often will see it too, but what I will feel is almost that there's almost like a bulging kind of motion that the pelvic floor does onto my finger.
Okay.
And then the last thing that I like to do is palpate their TA. So remember, I said I like to wait to palpate the TA till I have my hand on the pelvic floor. I ask
Okay.
them to do a TA contraction. Their pelvic floor should co-contract with the TA without me. So I don't ask them to do anything with their pelvic floor. I just teach them a TA contraction. What I'm looking for here is does it coordinate automatically or do we maybe need to reteach it how to coordinate? So that falls into that motor control bucket a little bit more.
Okay.
Sometimes I will ask them to do a Kegel and see if their TA also activates. That's probably less relevant for the majority of the people listening to this podcast. So you could probably just stick with the TA and see what the pelvic floor does. And that's it.
Okay. Got it. So that's that's the assessment portion.
Yep.
Okay, I will do my best to
Nothing too
recap
crazy.
it. Yeah, I'll do my best to recap it. We'll take a few minutes to talk about interventions and prognosis, and we'll wrap up because I know it's getting late for you, and we both have work. So, recap: we have three buckets: overactive, underactive, and motor control. And it appears that when we are looking at this stuff, um, Oh shoot. I'll do what I can, and we'll see what we get done. So if you are palpating around the abdomen and you note a tissue change, and they're guarding in some way, does that give us any specific insight into the pelvic floor itself?
We know that that is going to have an impact on the pelvic floor because, again, it's playing in the same sandbox, so to speak,
Sure.
but we it doesn't necessarily tell me what the pelvic floor is going to do. The
Okay.
pelvic floor might be guarding too, or it might have been like, "Well, that abdomen's squeezing for all it's worth, so I'm just gonna go on vacation," and I don't know until I assess more.
Okay, got it. So we move away from the abdomen and we screen the hips and the pelvis and all that good stuff. And if that is not, uh, I'm not really sure how that ties into the pelvic floor.
Um, it is more so that we're just looking at these structures that are related to the pelvic floor,
Okay,
because if I have limitations in hip mobility or spine mobility or pelvic mobility, all of that is going to impact the workings and the functionings of the pelvic floor. So it's not necessarily going to give me a diagnostic or treatment hint for the pelvic floor itself, but if I work on my pelvic floor until the cows come home and leave that hip where it has no internal rotation, I'm probably gonna had hit a plateau sooner than I have to.
okay, got it. So it would seem that uh, the actual palpation of the pelvic floor by the sit bones is a really, really big kind of pusher of what direction we go. Would you say that's true?
Yeah, I would say that combined with just watching people move and looking at their movement strategies are sort of the
Ah,
2 big ones for me.
got it. Because if they hold their breath, we're looking at underactive
Um, a lot of the time, yeah,
or motor control.
or motor control, yeah.
Or motor control. And then we talk about an independent Kegel. The ability or inability to do that will push us more underactive or motor control.
Right.
Okay, got it. And so when you're palpating the pelvic floor itself and you have them cough, and it bulges or it doesn't pre contract and then contract, obviously, what bucket does that put us in?
Typically motor control, although
Okay,
that's a piece of information that you need to use with all the rest of your
absolutely.
information, but most of the time that's motor control because, again, that should be just happening without people thinking about it, and even if we're underactive, we still shouldn't bulge. Does that make
Okay,
sense?
right.
Yeah.
Yeah, got it. And if it is painful on either side or it feels tight, it may very well be tight,
Mhm. Oh,
which
and
would
I forgot. One another thing that's really great, I don't usually do this because I have that internal skill set that helps me, but the adductors almost always mirror what the pelvic floor is doing. So if you
okay,
palpate the right-sided adductor and you're like, "Man, this thing feels like an iron cable," and the one on the left feels normal, pretty certain that that right side pelvic floor is also overactive.
got it. And an overactive, painful to palpation, or just simply excessively tight would put us more overactive bucket.
Yes, typically.
Okay. So I want to be respectful of your time. It's getting late for you. If would you kind of tell us how maybe some general interventions to begin with for each of the three buckets?
Sure. So the general intervention to start with for all 3 of them is actually the same, which is
Okay.
weird in PT, I realize, but it's also kind of lovely for
Yeah,
those of
that's
you
great.
that don't necessarily want to go super in depth with pelvic floor training, because this intervention will help no matter which bucket they are in. So,
Great.
hooray.
Great.
And it is diaphragmatic breathing.
Okay.
I know. Our patients breathe all day, at least we hope. But a lot of them are chest breathers and they're not
Okay.
using their diaphragm. They're not expanding their rib cage. By the way, you probably should check thoracic spine and rib mobility sometimes in these patients as well.
Okay.
Um, but if you can get their diaphragm moving, their pelvic floor will also move. It is a reflex, they can't prevent it, and that will help tremendously. So, if you teach them to drop that diaphragm and their pelvic floor is overactive, guess what? That's actually an active stretch for the pelvic floor. That's one of the only ways that you can truly stretch the pelvic floor because it's not like our other muscles where it's like, oh, I can move this joint and it'll stretch. That's not going to work for the pelvic floor because it doesn't really attach to mobile joints like that. So that diaphragmatic breathing will help with range of motion, mobility, and the ability to elongate. Again, whether or not they're doing anything volitionally with their pelvic floor. If they have issues with motor control or underactivity, again,
Mhm.
that pelvic floor, if you get that diaphragm moving, the pelvic floor will too in both directions. And that can start to build a foundation for you to reteach proprioception of the pelvic floor. Does this person have any awareness of what their pelvic floor is doing and how to get it to do it more? So if we're
Okay.
underactive, that's where we're focusing at the beginning. A lot of times is like, okay, feel what this is doing, feel where my hand is. Do you feel how it's lifting when you exhale and dropping when you inhale? And you might have them really exaggerate both of those to get a bigger movement so they can feel it. And I'll be like,
Okay.
okay, that's great. Let's make it do it a little bit more. And then we can start layering on these other muscles. If it's a motor control issue and you can get the pelvic floor and the diaphragm moving together, then you get to cheat and you can use breathing to force them to have motor control with these movements that they're currently not. So, what I mentioned earlier, where, hey, I'm having leaking every time I stand up out of the chair. If you get them to exhale while they stand up, that will take care of the leaking the vast majority of the time. And the
Right.
reason for that is because they've got this relationship going and it will balance all the other things out. The really
Okay.
cool thing for the pelvic floor is most people at some point in their lives had a pelvic floor that was functional. That motor pathway exists. It's just a matter of finding it and lighting it back up. And so, a lot
Right.
of times, what we'll find is you do these early interventions of the breathing and the mobility and those early kind of teaching them how to feel what their pelvic floors are doing. And
Mhm.
then it's like a switch flips and it's like, oh, all of a sudden now they're not leaking while they're running because their brain was like, all right, there's muscles down there. I should maybe use those for
Yeah,
other things. So that's really cool. I think I mentioned pelvic floor informed cueing earlier in the podcast.
you did.
Really, all that's involved in that, you guys are already doing pelvic floor exercises, which is really cool. All of your core exercises, all of your hip exercises, all of your lumbar exercises, anything that you're currently doing with your patients can be turned into a pelvic floor exercise, which is really cool.
Okay.
Most of the time, all you have to do is have them exhale on the harder part of that exercise and really focus on form. So inhale on the easy part, exhale on the hard part, focus on form. That will not work 100% for everyone because nothing works 100% for everyone. But if
Sure.
all you add is teaching your patients to breathe, those kind of pelvic floor informed cueing or cueing when to do breathing, and then working a little bit with mobility in the abdomen, that is going to dramatically improve your functional outcomes. And yes, you will still have some patients who really probably need a more intensive skill set or someone who's able to go into a lot more detail, and that's okay. I will tell you, I still think that's a win because I cannot tell you how many patients have come through my doors and said, I've been searching for answers, and not even kidding, this is common, for 20 to 30 years. Why
Oh,
didn't anyone tell me to see a pelvic floor PT until now? So it
yeah.
is not a failure for you to say, hey, I think that we could benefit from a closer look at this. Let's see if we can get you in with a pelvic PT. And by the way, I know enough to where in that 6 weeks or 8 weeks or however long until while you're waiting for that person to have an opening, we're going to get started with some of these things that can help your pelvic floor. And then that way you kind of wash out some of the noise, and their pelvic floor therapist is going to have a really good blank slate to work with in a lot of ways where they can go, oh, it's very obvious what the problem is because you've already addressed a lot of those confounding factors.
Got it. So, it sounds like diaphragmatic breathing and breathing during exercise is really the key
I would say
because
so.
like you said, like Kegels are not very effective because it's
They're
like
not
just doing
functional.
right. It's like just
I
doing
compare
bicep curls.
Kegels to quad sets. Quad sets are important. They've got their place. It's
Sure.
primarily proprioceptive, though. We would never, ever, ever make our post ACL rehab protocol consist purely of quad sets, right? That's the
Absolutely.
foundation. And in the same way, Kegels have benefit, they have value, but that cannot be the endpoint because that doesn't make the pelvic floor do anything different functionally.
Right. Okay. So, diaphragmatic breathing, and just curious I've really got only two or three questions. We'll wrap up. Diaphragmatic breathing. Do you cue it one hand on the sternum, one hand on the belly, and trying to? I, I'm curious to see how you would cue that as an
Yeah.
expert.
That's how I used to cue it, and I actually
Okay.
don't like that way because I think it leads to people doing really wacky things where they're like they take a deep breath here and then they're like, "Oh no, that's not right." And then they really expand their belly and it's odd. So
Sure.
what I actually like to do is put my hands or even better their hands on the lateral lower rib cage
Okay.
and tell them it's like a balloon. I want you to blow up the balloon. So I don't actually want just belly breathing. That's not diaphragmatic movement either. That's using your abdominal muscles to suck air through your
Mm,
lungs. I want
okay.
you to expand in a 360. So often hands work well for that. If that doesn't work and they need more proprioceptive feedback, it works fantastically well to use like a stretching strap or a strong TheraBand or even like a robe belt or a dog leash or something like that at home wrapped around the waist, not for resistance, but for proprioception. I want you to try to expand evenly into this entire circle. And that tends to work
Mm,
really, really well. And if
okay.
it's not working in the position that you're in, change positions. Sometimes people have very ingrained motor patterns for how they breathe while they're laying down, weirdly
Got it.
enough, probably because we spend so much time lying down to sleep. So
Okay.
if that's not working, sit up, sit on a physio ball, stand up, quadruped, whatever you have to do to get that movement started. And then once they get that success in one position, it's often easier to transfer into another.
Okay, great. And I think the other questions, myself included, will have. Um, how are you doing manual techniques to the abdomen if you feel that it is restricted?
Mhm. A lot of times that's scar tissue mobilization. So again, you know how to do scar tissue mobilization, just maybe haven't done it there before.
Yeah.
But I'll use my hands. I do cross friction, myofascial release, all the things. Cupping actually works really well in the abdomen as kind of a tool assisted option. So if you do cupping, that
Mhm.
can be great. Some people have found a lot of success in dry needling in the abdomen, especially around scar tissue. Obviously, don't try this at home unless you've actually taken a class to dry
Sure.
needle through scar tissue in the abdomen, but
Sure.
it can be very helpful, especially with C-section scars.
Okay.
And then actually, kinesio tape is very helpful for soft tissue mobility in the abdomen. Just
Okay.
stretch the living daylights out of that stuff and stick it down right over the scar, and it gives a nice lifting release that can help promote blood flow between sessions.
Oh, wow. I have a patient coming in tomorrow. I may very well try that.
Try it.
The one that we talked about, the one with
Oh,
the
perfect.
abdominal C-section stuff.
Yep.
My sweet girl. And second, and my other question is there any, do I ever need to do like ischemic compression or any manual intervention? Daisy, don't drink right now, sweet girl. Wait a minute. Are there any manual interventions to the pelvic floor specifically
There are
that are not
those I
internal?
would yes, there are. Those I would hesitate to try to describe on a podcast because
Fair
they're
enough.
very specific.
Got it.
I again, there is an entire class through Evidence in Motion. The Pelvic Health 1 class is 100% external. It's evaluation and treatment. It's available actually both online and in person, so people can take it either way. But that is taught in detail there. I just don't feel comfortable trying to describe it
Oh,
because it's a lot of it
absolutely.
is feel and very specific hand placement that's just really hard to convey if you're not there with your hands on somebody.
Absolutely. And really, like, it's good to know that there are certain things that can't be taught over a telehealth
Yes.
or a Zoom meeting. So this has been amazing. I just have one question whether that I told you I would ask for the people that asked on the podcast on the page. They were curious if there is any um, thoughts on how hypermobility or EDS, like Ehlers-Danlos syndrome,
Mhm.
would impact pelvic health.
I never in my life saw so many EDS patients until I started treating pelvic health. It
Okay.
does. It absolutely does. They do really well with pelvic floor rehab a lot of times. But yeah, if you're hypermobile, a lot of times your poor pelvic floor, and not just the pelvic floor either, a lot of your muscles, but a lot of times your poor pelvic floor ends up like really carrying a heavy load trying to keep up. And so often they fall into that kind of overactivity category much of the time, but
Right.
again, respond really, really well to treatment.
Right. Because they're holding on for dear life. But again, going back to what you said, diaphragmatic breathing and then breath cueing during exercise, exhaling during the hardest part of the exercise,
Yep,
inhaling during the return.
yep.
Um,
Good
I
resistance program with some diaphragmatic breathing makes a world of difference.
I guess last, it's literally just a quick detail. How long do you have people diaphragmatic breathe? Do you have them do 5
Ooh,
minutes, 10
that's such a
minutes?
good question.
Right. And obviously there's no explicit always 100% answer, but do you have people start with like 5 minutes? Or
So I don't. Well, I do have them start with a time period, usually between 1 and 5 minutes, and
okay,
I tell them I want them to set a timer. I don't want them to count because I don't want their frontal lobe engaged. I want them really able to just focus on the breathing. But
got it.
even better than that is, can they tie breathing to something that they're doing a lot during their day? So, for example, I get on way more meetings in a day than I necessarily would really like to. If I can do 10 diaphragmatic breaths at the start of every meeting, that is going to add up tremendously through the course of my day. And the reason I
Okay.
like that, tying it to a regular activity, is because this is something that is supposed to happen under the radar all the time without us thinking about it. One of the best ways to cue the brain to do it is actually not to do a large amount in a short period of time. It's to do a little bit repeatedly throughout the course of your day. So that's why I like to try to tie it to that activity.
Got it. So, for anyone listening, thank you for joining us tonight. I'm sure we could potentially have a more intervention driven podcast in the future to get into more details. But seriously, Jen, thank you.
Yeah, of
I,
course.
I cannot thank you enough. This has been incredibly helpful for me. And my boss is going to be like, why are you asking so many people about pelvic floor and like all this other stuff? Probably starting tomorrow. Because
My
I have
standard answer is it's not my fault everyone has a pelvic floor.
right. So I just want to say thank you, Jen. Is there anything you would like to end with? Anything you'd like to say before we close out?
I think the main thing is just encouraging people not to be scared to start trying to apply what knowledge they have, even if it is just diaphragmatic breathing, because application of whatever skills you have to offer people in this area is worlds better than what most other providers, including their physicians, are able to give them. And if you can help even one person go a little bit further or help with their incontinence as well as their low back pain, or not be back in your clinic in 6 months with that same old SI joint pain, I think it's worth it, and it'll be a lot more than one person. But yeah, don't let your fear or lack of comfort around this area be a deterrent, because it's really not as different from treating all of these orthopedic diagnoses that you are comfortable with as you might think.
Okay, awesome. Well, thank you, Jen, and thank you to everyone who has stuck around for this conversation. As always, happy to have you, and we'll see you guys next time. Thanks for listening tonight, you guys. It would really mean a lot to me if you found a benefit from this episode. If you could stop by and give the podcast a rating, as well as check out my Instagram page at Perfecting PT for updates on episode releases, upcoming episodes that you'll get the chance to give me questions to ask the wonderful guests we have, and just help other people know that there are better ways to treat and different systems we can use so that we can all grow and become better. So, thank you so much for your time, guys. I hope you're doing well. Thanks for what you do, and I'll see you next time.